Dr. Sam Osai. So without much ado, I'll ask Sam Osai to introduce his team and I'll let it roll.
Yes, thank you very much, Chairman.
Dr. Sam Osai,
thank
please.
You very much. Thank you very much, Chairman, and thank you very much.
You need to speak up, we can't hear you well.
Keke for putting all this. Yes, thank you very much, Mr. Chairman, and thank you very much, Dr. Keke, for putting all this together. On behalf of Naus, I would like to welcome the almost 23 participants in this meeting at the moment, and I'm sure we're going to be much more. We are over the next couple of hours. We're going to be discussing a very important subject, very important in Nigerian urology, the subject of urolithiasis. We have four speakers. Dr. Jowola from Naus will be speaking on the epidemiology and etiology. The clinical presentation and investigations by Dr. Limesh of the Misa Premier Hospital, Abuja. And then the principles of medical treatment by Dr. Opani of the University of Port Harcourt Teaching Hospital. And of course, to sum it all up, ESW will be discussed by Dr. Magnus of Chivas Hospital. I would like to appeal to the speakers to try and keep their presentations within the time allotted. We don't have to use up the 20 minutes, but try and make your presentation within that time. So I would like to call on Dr. Ojewola of Lagos University Hospital to begin the presentation with the epidemiology and etiology of urolithiasis.
Yeah, good afternoon, Mr. Moderator, the executive of Naus, and members, ladies and gentlemen. It is my pleasure to introduce the topic of discussion today, urolithiasis, and I'll be talking about epidemiology, etiology, and the etiopathogenesis. I will use this outline to have this discussion this evening. As a way of introduction, urinary tract stones called urolithiasis is formed from two words, uro and lithos. Uro meaning urinary tract or urine, and stone means lithos. And it is a major affliction of that causes morbidity involving urinary tract. Urolithiasis is the third commonest afflictions in the urinary tract after urinary tract infection and the diseases of the prostate. Although stone disease is one of the most common afflictions of modern society, it has been described since antiquity, with the first urinary stones found in Egyptian mummies about 4,000 to 5,000 before Christ. The overall estimated annual expenditure on stone is quite high, and it runs into billions in the United States and in Europe, where they have facts and figures. And it is also important to know that with the westernization of global culture, the site of stone formation has migrated from the lower to the upper urinary tracts. No doubt, a lot of revolutionary advances has occurred in the management of this condition. However, there have not been so much understanding or improvement in terms of the etiology of this condition. The lifetime prevalence of a person developing stone generally is about 1 to 15%. However, this varies with a lot of factors, including geographical location, age, gender, racial and ethnic differences, climate, and a lot of others. In regions where a lot of works have been done on this subject, like in North America, their prevalence is quoted to be about 7 to 13%, that of Europe 5 to 9, and that of Asia 1 to 5. However, there is a global phenomenon of increase in the prevalence of stone, even in our environment. Generally speaking, in the past, historically, stones used to affect adults, but we are beginning to see pediatric population developing stone disease. The peak age used to be between 30 and 50 years, but there have been some changes as this has widened between 30 and 60 now. In terms of gender, historically, men are usually more affected by stone disease than women. And ratio in the past used to be like ratio of 2 to 3 to 1. But this ratio over the years has reduced to as low as 1.5 about 10 years ago. And recently, there are studies that have shown that even it affects females more than males. But most literature still puts higher incidence and prevalence of this disease in men. A lot of factors have been adduced to increased prevalence in men. The protective effects of estrogen against stone formation in premenopausal women, which causes enhanced renal calcium absorption and reduced bone resorption. Women. And of course, we also have studies that found androgen to increase urinary and serum oxalate in experimental model, and they found estrogen to decrease this. So all this makes men to be more predisposed. But there are changing trends as more and more women are developing stones now. In terms of racial and ethnic differences, a lot of studies have also put it that white men are more predisposed than Hispanics and Asians and than Africans. And in terms of geography, the geographical distribution of stones tend to roughly follow environmental risk factors. A higher prevalence of stone disease is found in hot, arid, and dry climates, such as the mountain, the desert, and tropical areas. However, genetic factors and dietary influences may outweigh the effect of geography, and that may be the reason why, even though we live in deserts and our temperature is generally higher, the prevalence of stone is not as high as we have in some other temperature region. In terms of climates, there are seasonal variations, and the highest incidence of stone disease has been found to be in summer months, between July through September, and peaks usually 1 to 2 months after the maximum high temperature. In terms of occupation that also predisposes patients to high temperature. Cooks and engineering room personnel also have higher rates. Sedentary occupations in those with managerial and professional position has also been found to carry increased risk for unclear reasons. But this may be as a result of a more indulgent diet and lifestyle. This table shows the, summary of epidemiologists from different parts of the world. And we can see in the United States, 12 to 18, and in Canada is even, like 15 to 5, and lower in Asian countries like India. In Nigeria, what do we have? What figures do we have? These are studies done by some of our prominent urologists some decades ago. Esho in Lagos in 1978 documented that urinary calculus is actually rare in Nigeria by this study. And about a decade after, Mbonu from Enugu also documented the prevalence of urolithiasis in African population, which was also said to be high. But what has happened? Aside from this, in 1989, in Benin, Johnny U. Monu also documented the risk to be about 6.3 per 100,000 population, and Equere in 1995 documented to be 19.1 per 100,000. The more recent study about prevalence of stone disease was carried out by Isaac et al. In Abuja in 2018, that's just about 5 years ago, among scanned patients, is a radiologist, and noted that the prevalence of stone is about 13.4 per 1,000 scanned patients. So as we can see, even from individual experiences and experiences of members on this platform, we will see that stone disease is not as rare as previously thought. What is the cause of stone? The etiology of stone remains speculative. However, there are various risk factors. And it might interest us to know that no obvious cause in some of these patients, even patients with recurrence. Because of this, there are many theories that try to explain how stone is formed in humans. Let's quickly talk about the risk factors. We can classify them into intrinsic factors. These include hereditary and genetics, like race. As I said earlier, the second thing is that the urinary tract disease also runs in family. So we have family members who have stones, and other family members have it, maybe as a result of genetics or a common environmental factor like diet. We also have patients with familial renal tubular acidosis, which is a disorder of absorption of hydrogen. And we have type 1, that's type 1. In type 2, that's a problem with the reabsorption of citrates, and we even have type 3. Anyway, all of this accumulates in an acidic environment and makes stone to form in them. We also have other disorders or hereditary problems like cystinuria, which is an autosomal recessive, autosomal recessive disease, and abnormal intestinal absorption and renal tubular absorption of basic amino acids like cysteine, ornithine, lysine, and arginine, and this leads to accumulation in the urine. We also have patients with primary oxaluria, which is also an inborn error of metabolism, where the liver enzyme called alanine glycosylate aminotransferase, which actually convert glycosylate to glycine. When this is absent, the glycosylate are converted to oxalate, and it leads to oxaluria, and patients develop stone disease. And we also have other conditions like santinuria and hypophosphatemic rickets, as we will see later. Intrinsic factors also include things like gender, as I mentioned earlier, but of course, the gap is narrowing. And of course, age also plays a role, as it is more common in elderly. The extrinsic factors, I've talked about some of them: geography, climate, the water intake. People who are dehydrated theoretically are also more predisposed to developing stone. And of course, in terms of diet, high concentration of solutes in the urine from red meat or more indulgent diet and lifestyle may also predispose a man to developing urinary calculi. Socioeconomic status, affluent individuals, countries, and societies, as we have seen in some of the table. And of course, occupational exposure are some of the intrinsic factors. Of course, there are some acquired conditions that predisposes a man to developing stone. For example, patient who had surgery like ileal bypass, because of the little length of intestine available for oxalate reabsorption, more of these oxalate are absorbed, and we have oxaluria eventually, and this leads to formation of oxalate stone. Patient with ileostomy, there is increased loss of bicarbonate, and that leads to acidosis. And of course, in acidic urine, uric acid stone will form. And of course, patients also who have had previous kidney surgery. Acquired pathologies include Crohn's disease, which also impairs with oxalate reabsorption, short bowel syndrome, which also affects oxalate reabsorption, and of course, any condition whatsoever that will lead to increased calcium level in the urine, as we will see later. Also, urinary tract infection is a predisposing factor to to stone formation, particularly infections with urea splitting organisms like Proteus mirabilis, Pseudomonas aeruginosa, Klebsiella, Corynebacteria, and even Staphylococcus. And of course, more recently, a number of studies have also shown correlation between stone formation and metabolic syndrome, including diabetes, cardiovascular disease, and of course, patients with chronic kidney disease. Other things that could predispose a patient to developing stones are urinary tract abnormalities, like medullary sponge kidney, or any form of obstruction, uretero-pelvic junction obstruction, posterior urethral valve, and any other form of obstruction will, increase the likelihood of stone formation in a patient. Of course, patients with gout, uric acid abnormalities, as we see later, are also more predisposed. And of course, stones can also form from drugs. There are lithogenic drugs. Indinavir, used for RVD positive patient, and tramterine, which is actually an antihypertensive, can actually also form stone. In terms of physical chemistry, mineralization in all biological systems has a common theme in that the crystals and the matrix are intertwined, and urinary stones are no exception. They are polycrystalline aggregates composed of varying amount of crystalloid and organic matrix. So stones generally has crystal components, which most time is the most predominant in about 80 to 90% of stones. And they also have matrix component, which is present in about 2 to 10%, depending on the type of stone. It can even be as high as 60 or 80% in some set of stone called matrix stone. But generally speaking, there are more crystal components. So if we have these as the basis that we found all these in all stones, let's quickly look at some of the things that can happen to the metabolism of these ions or crystals or solids that can predispose a man or lead to stone formation. There are major ones like calcium oxalate and uric acid, and there are minor or intermediate ones. Calcium is a major solid that is responsible for stone formation. So anything whatsoever that will lead to hypercalcemia, and which ultimately may also lead to hypercalciuria, or there may not even be hypercalcemia, but there may be some factors that as a patient, makes a patient to lose more calcium, then that patient can actually have stone. Usually, calcium secretions is about 100 to 150, but in patients with hypercalciuria, they may have as much or even more than 350 milligrams in 24 hours. What are the causes of hypercalciuria? Generally speaking, they can be divided into three: absorptive, resorptive, and renal induced. In the absorptive, there is increased absorption of calcium. And because of increased absorption, there is hypercalcemia. And this causes an increased load of calcium from the glomerulus. And because of this, there is suppression as a feedback mechanism of parathyroid hormone. And this ultimately leads to reabsorption of more, decrease the reabsorption rather. And this leads to high concentration of calcium in the urine. There are three types of these absorptive hypercalciuria. We have type 1, which is usually independent of diet, found in about 15% of all patients with stone, and is usually calcium independent, and usually we treat it by just getting something into the intestine that will make calcium unavailable for absorption, usually treated by cellulose. We also have type 2. Type 2 is actually a milder form of absorptive hypercalciuria, and is usually diet dependent. No specific treatment required for this one. A calcium restricted diet is enough to correct these abnormalities. And of course, in type 3 is actually due to a phosphorenal leak, where we have decreased reabsorption of the phosphates at the kidney level. And because of this decreased reabsorption, there is now stimulation of 1,25 dihydrovitamin D synthesis. And this leads to a cascade of events, which will lead to increased absorption from the intestine and also increased excretion. Hence, even though it is of renal origin, but because of the eventual increase in absorption of calcium from the intestine, it is also regarded as an absorptive hypercalciuria. Secondly, we have resorptive hypercalciuria, usually as a result of excessive parathyroid hormone production, which prolong immobilization or excess intake of vitamin D. We also have renal induced. In renal induced, there is decreased reabsorption of calcium, and this results in wasting of calcium, and there are a lot of calcium in the urinary tract, in the urine, and this gives room for precipitation and other events that happens later. The second most important solute in the urine that is responsible for stone is oxalate. Usually, it's relatively insoluble, just few percentage is absorbed. But in oxalate, unlike calcium, diet has a role to play. The presence of calcium, which complexes with oxalates, all these things reduces the amount of oxalate that are absorbed. Any other factor, like short bowel syndrome, as we mentioned earlier, Crohn's disease, that will not allow intestinal mucosa to be available to allow more of the oxalate to go into the stool, will make more to be in the system, and that will also lead to hyperoxaluria. For oxalates, very small increase can actually lead to spontaneous crystallization and is an important factor in etiopathogenesis of stone. Causes inborn error of metabolism, inflammatory bowel disease, as I mentioned earlier. Uric acid is another solute that is very important. Hypersecretion, usually more than 600 milligrams per day in women and 750 in men, will be as a result of high purine intakes and, of course, increased endogenous production. Both will lead to increase in monosodium urate, and this will absorb urinary stones inhibitor. And when there are no enough inhibitor, then the process of heterogeneous nucleation will commence. In excessive uric acid, there can actually be two types of stone forming: hyperuricosuric calcium nephrolithiasis, and there can be also be hyperuricosuric acid nephrolithiasis. In the first, usually the pH is usually slightly more than 5.5, while in hyperuricosuric acid it's actually lower. Cystine stone is usually found in young women, also due to inborn error of metabolism, and this leads to abnormal intestinal absorption and renal tubular absorption of diphasic amino acid that I mentioned earlier. It is inherited in autosomal recessive fashion. Citrate is a key factor in calcium urinary stone. It complexes calcium, makes it unavailable. So when there is deficiency of citrate, it is associated with increased stone formation. So factors like chronic diarrhea, renal tubular acidosis, or chronic thiazide therapy are things that can decrease citrate and will enhance or increase the chances of stone formation. There are few other metabolic stimulus like fasting that causes acidosis, hypokalemia, hypomagnesemia are things that can actually also affect citrate concentration. And as I mentioned earlier, estrogen increases citrate excretion. Therefore, there is abundance of citrate in the urine, and that is probably one of the factors why stones are less common in women. Yes, sodium
Excellent.
plays a major role in regulation calcium crystallization. Also,
Dr. Jowola, please look at your Dr. Jowola, please look at
yes,
your message.
please.
I've sent you some message. I've sent you some message.
Message
I
to
sent
my
you some message. Yeah. Yes. No. To your on the Zoom.
on the
I
Zoom.
was telling you that you've exhausted 20 minutes now.
Oh,
yes.
20 minutes
Yes.
gone.
That's right. I
Oh my
started
God.
warning you since it was 10 minutes
All right.
ago. But
Okay.
that's fine. We'll give you 5 minutes. We'll give you 5 minutes to
Okay.
finish it.
All right. Okay. So those are crystals. Then the mastery component including mucoprotein, proteins, and carbohydrates. Now, mechanism of lithogenesis. There are many questions with no clear answer as to why are stones formed. We cannot understand up till now why most stones are in unilateral fashion, one side, the other not affected. We can understand why some forms in small size and some are bigger. And of course, we can't understand why stones, when they are very small, do not pass that time and they have to wait until they become big and they become. So no single explanation suffices, and therefore many theories suffices. Are propounded. The first is supersaturation theory. The central event in stone formation is supersaturation of urine. And of course, the ions that we mentioned earlier, the solutes, when they are not in enough quantity, when the solvent is more than the solute, the urine is undersaturated. But as the concentration increases, then we have a solubility product. At these solubility products, usually stones are not formed. But by the time the solubility, the concentration is exceeded, urine is in a metastable state. And at that stage, depending on a number of factors, it is possible for crystallization to occur. But by the time this increases, it gets to a time when the concentration, the activity product gets to formation product. And at this stage, even homogeneous nucleation can occur, heterogeneous nucleation can occur, and it is very likely that stone will be formed. This picture is just showing at this level, we can see solubility product is not likely that stone will form here. But by the time it exceeds this solubility product, at this state, it is metastable. So it depends on a number of factors. How much inhibitors are in the urine, and a lot of other factors. So at this stage, the other environment, like even the pH, will determine what happens. But by the time it gets to formation product, usually inhibitors are not generally active and stone will form. We also have nucleation process, suggests that urinary stones originate from crystals, so may merge in supersaturated urine. Homogeneous nucleation means complexation of identical ions. And of course, this aggregates and it continues to grow in size. And of course, we have, this supersaturation theory itself cannot explain it, because why are these crystals not passing at the initial phase? There are other theories that try to, explain possibility of fixation of some of these to some, structures in the urinary tract. We also have matrix nucleation theory. Incipient clots, scars, epithelial cell debris, and casts at foreign body are things that could be nidus and bind crystals and initiate the process. We also have epitaxis theory. That is a heterogeneous nucleation when crystals forms on surface of another crystal. And that is why, we have some of our stone laminated, grows on surface of another. Calcium oxalate on uric acid and sodium on urate are examples. We also have promoter inhibitor theory, that is imbalance between the promoters of stone formation and inhibitor of stone formation. These are the inhibitors. The chief inhibitor is citrate, but others are also important. Stasis is another thing. Urine takes a very short time. Anything that is responsible for blockage of urine passage and increase the time will encourage precipitation and can also increase the stone. There is also Fitzpatrick theory, which says that these functions are actually retained within cells or beneath the tubular epithelium. And Alexander Randall actually noted this whitish yellow precipitation of crystalline substances occurring at the tip of papillae. These are usually seen at endoscopy. These are some of the theories that try to explain how stones are formed. These are the stone varieties, calcium stones, and of course, non-calcium stone. Calcium stone predominates 80 to 85%, and these are examples of non-calcium stones. There are other specific stones, and these are some things we need to look for in evaluating and in diagnosing them. Time will not permit me to go into the details of this. These are some of the characteristics of uric acid stone: hard but smooth, multiple, 16 soda, usually multiple, radio opaque. And of course, there are rare stones or peculiar stones, sandstone stone, matrix stone, Indinafi stone. All these have some peculiarity. They are all radiolucent and they may not be seen on X-ray. So in terms of nomenclature, we have, when you read textbook on stone, you will hear a lot of names. Wewelites refer to calcium oxalate monohydrate, weatherite calcium oxalate dihydrate, bruchite calcium hydrogen phosphate dihydrate, and wheat lutolite tricalcium phosphate. And we have strufite, named after a German naturalist, magnesium ammonium phosphate hexahydrate, and there are a few others. In terms of stone composition in Nigeria, few studies have been done by Ondi et al. In Abuja and Mecca et al. Somewhere in the east. And we also see that the predominant stones in this country is calcium oxalate. In conclusion, stone disease is a common urological problem worldwide, including Nigeria. Proper patient evaluation to unravel predisposing factor is very important. And of course, this will help in the development of medical prophylactic program to prevent recurrence, which is quite common. If you want to prevent recurrence and want to formulate a medical prophylactic program, a good understanding of etiology and pathophysiology of stone formation is imperative. Thank you for listening. Thank you, sirs.
Yeah. Thank you very much, Dr. Jiwola of Lagos University Teaching Hospital. That was a very difficult subject to try to cover within 20 minutes. I think the plan is to have questions, to have commentaries and questions on the presentations at the end. So without wasting more time, we move ahead to the presentation of Dr. Limek Nabasu, of the NISA, consultant neurologist at the NISA Premier Hospital, Abuja, on clinical presentation and investigation of urinary tract stones. Dr. Nabasu, please. And please just know that once you have spent about 15 minutes, try and look at your message. I will warn you by sending you a message. All right?
Okay, sir.
So just so you are aware, so we'll keep it to 20 minutes. Thank you.
Okay, sir.
Please go ahead.
Okay. Okay. Good evening, my teachers and colleagues. Can you hear me?
Yes.
Hello? Okay.
Yes.
Very well, very well. The audio is very clear.
Okay. So it's a pleasure to present the clinical manifestation and investigations of urolithiasis.
Dr. Jiwola, please stop sharing your screen.
I have done that. Okay, all right.
Nabasu, now you
Yes,
can
sir.
start sharing your screen.
Okay, I've done that. Can we see the screen?
Not yet.
Not yet.
Oh, okay. Okay.
You just click that green share screen. Good.
Is it visible now?
Yes, but go
Yes.
to slideshow. Okay.
Okay.
Yes,
Okay.
go ahead.
Excellent.
Good evening, my teachers and colleagues. It's a pleasure to present the clinical manifestations and investigations of urolithiasis. And I'll present in using the following outline. Generally, the presentation of patients with urolithiasis depend on the location of the stone and the presence or absence of complications. Present with pain of the stone. In the flank, the pain might be colicky or non-colicky, usually arising from stretching and stretching of the calyces or the renal capsule. Usually the collecting system or the renal capsule is stretched, leading to obstruction with subsequent increase in intraluminal pressure and so the pain. That is to say that the pain may not always wax and wane, but it may rather be constant. A vast majority of patients present with sudden onset of pain that might wake them from sleep. And the severity of the pain also depends on the degree of obstruction, the stone size and location of the patient of the stone, as well as the patient anatomy, as in extrarenal pelvis versus intrarenal pelvis. It is more in patients who have extrarenal pelvis because the increase in intraluminal pressure usually builds up early, leading to severe pain. And this pain, like we said, is usually sudden in onset. The stone burden, however, does not correlate with severity of the pain. They frequently move from one position to another, usually in search of relief of the pain. And this may be aggravated by intake of large amounts of fluid. The pain, usually the character, like you said, depends on the location of the pain, of the stone. In the renal calyx, the pain is dull, aching in nature, usually in the flank or the back, mild, moderate to severe, and it may result in complications like perforation, leading to urinoma, abscess formation, and fistula. And this subsequently would modify the presentation of the patient. In the renal calyx, in the renal pelvis, the stone commonly obstructs the pelvic ureteric junction, leading to pain of varying degrees, and it radiates to, it's usually located at renal angle, and it radiates to the flank and upper abdomen, and so may be confused with biliary colic and on the right, and pelvic gastritis, peptic ulcer disease, and pancreatitis on the left. However, escargot calculus may not produce the symptoms that we might expect based on the size, because it doesn't necessarily lead to obstruction of the urinary tract, and therefore it might present with few symptoms like flank pain or mild discomfort or flank pain. In the upper or mid urethra, often the pain, the stone causes severe renal angle pain and flank pain. And this may be intermittent as the stone migrates distally. Relief of this pain is usually, relief may be as a result of compensatory mechanisms like pyrolymphatic and pyrovenous backflow of the urine. The pain may radiate to the lower abdomen, and this might be as a result, it's usually as a result of the dermatomal distribution and spinal nerve root innervation. The pain from the upper ureter radiates to the lumbar region and the groin in that fashion. The pain from mid-ureter radiates to the mid and the lower abdomen, as well as the groin in a curved fashion. This pain that we're talking about may mimic acute appendicitis on the right and diverticulitis on the left. In the distal ureter, pain radiates to the groin or testicle in males and labia majora in females. It's often generated from the ilioinguinal nerve and the genital branch of genitofemoral nerve. Just like the other presentation, it might also be confused with some conditions like testicular torsion or epididymitis because of the location of the pain. Stones from the intramural part of the ureter will cause suprapubic pain frequency and dysuria, as well as strangury, but rarely may present with gastrointestinal symptoms. In the bladder and urethra, the symptoms might be that of storage, lower urinary tract symptoms, and lower abdominal pain, as well as urinary retention if the stone is occluding the internal urethral meatus. But this might be intermittent retention. Patients might also present with hematuria, which might be gross or microscopic, or they might just present with colored altered urine that might be described as tea-colored urine. Patients might also present with complications of the presence of stone, which include infections manifesting with fever, pyelonephritis, pyelonephrosis, and features suggestive of urosepsis. They might also present with nausea and vomiting, mimicking GI conditions, or features suggestive of acute kidney injury. The clinical examination might not necessarily reveal any finding, but patients usually present in painful distress if at all they present with pain, or they might present with pyrexia apart from the pain, usually due to infection, dehydration, due to incessant vomiting if they so present. They might present with pallor as a result of prolonged hematuria or renal angle tenderness due to pyelonephritis. The kidneys might be palatable on the affected site if a patient presents with pyelonephrosis. Otherwise, like I said, the patient may present with no clinical finding, depending on the time we're examining them. Investigations of urolithiasis might be grouped into investigations to find out or to confirm the diagnosis and the location of the stone, as well as the size, as well as investigations to evaluate the patient for metabolic derangement. In trying to find out or to confirm the diagnosis, CT-IVU is now the imaging modality of choice in the diagnosis of urolithiasis. It is accurate in diagnosing all patients except patients that harbor indenavere stones, which are usually not seen on CT. And this allows for accurate determination of stone size, location, as well as the pelvic calycial system, the definition of the pelvic calycial system. The plain abdominal X-ray used to be a common investigation though it is still in use, and it's of value in detecting radiopaque calculi, which usually constitute about 85 to 90% of stones. Usually contain stones. Usually those stones that are picked on X-ray contain calcium, and the more the amount of calcium, the more radio dense the stone is. In order of in descending order, calcium phosphate are more radio dense than oxalate, calcium oxalate, then followed by struvite as well as, and then cysteine stones. The problems with a plain abdominal X-ray is the fact that some radiolucent stones which might be present might be missed, and this form about 10 to 15%. Other causes, the other problems with X-ray is the fact that this radio opaque focus might be confused with other conditions, like on the right, gallbladder stones, as well as infiltrated feces, either on the right or on the left. Ultrasonography is also useful in the diagnosis of urolithiasis. It is highly sensitive in detecting renal stone, even though it depends on the size. And this manifests as a hypoechoic lesion with a characteristic posterior acoustic shadowing. It has the ability to detect radiolucent stones as well. That's one advantage of ultrasonography. Intravenous urography, useful for patients with suspected inguinal stones, which are not visible on CT. Otherwise, it has largely been replaced by CT scan. A radionuclide scan has a role in the investigating patients for urolithiasis. And this is important when patients they present with on CT delayed contrast uptake or non-contrast uptake and excretion. It's important because it will help in planning patients for treatment as well as for medical legal reasons. We're able to establish the function of the kidney accurately before we go on to treat the patients. And like I said, in planning, patients who have complete failure of that particular kidney might as well do well with simple nephrectomy instead of, depending on the site, on the location of the kidney, you might do well with simple nephrectomy rather than going for stone treatment alone. And radio tracers usually that will give us that information are MAC3 and DTPA. And like I said, it helps in planning. Investigating patients for the purpose of metabolic evaluation is also important. And this is part of the requirement for prevention of recurrence of stones because of the high propensity of some category of patients to have a recurrence in the future. And evaluation should be able to identify some conditions like distal renal tubular acidosis, primary hyperparathyroidism, gouty diastasis, as well as enteric oxaluria and cystinuria. There are indications for evaluation. Personal history of gout, come back again for patients also with solitary kidney, anatomic abnormalities, renal insufficiency, uric acid, cysteine, and struvite stones also merit metabolic evaluation. Large stone burden, patients with large stone burden, pediatric stone formers, and some professionals coming with stones will require metabolic evaluation, like pilots, and bus drivers as well as truck drivers, because the consequence of having those people, of having a colleague while they are on duty is catastrophic. Metabolic evaluation, usually there's an initial basic metabolic workup for patients, which involves a history, a brief history, and physical examination. This is geared towards finding out the diet the diet the patient is taking, fluid consumption, UTI, medications. Urinalysis is important, including the pH of the patient and urine culture as indicated. Like the previous speaker mentioned, the pH less than 5.5 is likely due to, the patients with pH of 5.5 or less will likely harbor uric acid stones, and those with pH of greater than 7.5 will harbor infection stones. Stone analysis of any recovered stone is very important in knowing the constituents of the components of the stone, and this helps in planning future preventive strategies. Serum chemistry involving urea, electrolytes and creatinine, as well as uric acid and calcium. If the calcium level is high or the stone composition is mainly of calcium phosphate, a parathyroid hormone should also be acid in the blood. Further evaluation, if initial evaluation is abnormal, is warranted. And this includes a 24-hour urine test involving the volume of urine, the measurement of the volume, the pH, the calcium, oxalate, citrate, and uric acid levels in the urine, as well as creatinine. Measuring the creatinine level is important in order to avoid errors, because the expected creatinine excretion in a 24-hour period is 20 to 25 milligrams per hour per kg in males, as well as 15 to 20 milligrams per kg in females. And in an event that the creatinine is in excess, this may mean that the urine has been overcollected, or the muscle mass of that particular patient is high. And the converse is also true, that if the creatinine level is low, it might also mean that the muscle mass is low and urine is undercollected. This is a way to collect the 24-hour urine, because patients might, if we don't educate them well, they can easily make mistakes in collecting the sample, and this will lead to misinterpretation of results. The patient will choose a day when voids can all be collected, and then he discards the first morning void, which is usually from the previous night. After discarding the first morning void, at that point, he starts collecting the urine, and this is collected in a container that is placed on an ice pack. When the patient wakes up the following morning, the void of that particular morning is added to it to make a 24-hour urine volume. So it is important to know this so that patients can be counseled and educated on how to collect the urine to avoid misinterpretation. So this is just briefly how we can, the presentation and the investigation of patients with urolithiasis. Thank you very much for listening.
Oh, yeah. Thank you very much, Dr. Limek Mabasu, consultant urologist at the NISA Premier Specialist Hospital of Abuja. We just kept to the 20 minutes allotted. Thank you very much. And as mentioned earlier, we are reserving commentaries and questions to the end of the 4 presentations. We shall go on now to the principles of medical treatment, to be presented by Dr. Okpani, consultant neurologist at the University of Port Harcourt Teaching Hospital. Dr. Okpani, please, you have 20 minutes.
Please, Dr. Nabasu, can you stop sharing your screen? Nabasu, please stop sharing your screen. Nabasu.
I'm not sure he can hear us.
Dr. Nabasu, can you stop sharing your screen?
So Zoom doesn't allow us to log him out or allow you to do that for him.
Okay, he has stopped sharing. Thank you.
Stopped. Okay. Okay,
Yeah.
now you can share.
Yeah, so good evening, senior colleagues and colleagues. My name is Dr. Charles Okpani. I'll be taking the presentation on the principle of medical treatment of urinary litiasis. I thank for the opportunity. Now, a lot has been already said about, can you see my screen, please?
Yes, go ahead.
Very well.
Okay.
Yes.
Yeah, so this is the outline I'm going to use. We'll go through the introduction, patient assessment, and different therapies. Now, the treatment of urinary litiasis can be medical or surgical. And of course, as urologists, we all tend towards the surgical care. And this is most important, especially when they present in a symptomatic manner. However, the medical treatment comes into play to prevent recurrence, and it's important that we have to assess our patient appropriately and investigate, as highlighted by the last speaker, to stratify the patient on those that will benefit from medical therapies at different levels. The role of medical management is often misinterpreted and misunderstood. We're always told that a stone usually should be treated surgically. So there's a tendency for most people to ignore the medical treatment, but it's important. And the medical treatment requires detailed clinical approach and laboratory adjunct to the sign of option. And this is an area of ongoing research. A lot of new drugs are being looked at also. Now, the indications for patient for medical therapy will include the first-time stone formers who are clinically stable with non-obstructive urinary stone, who have these are patients who also will have medical therapy to prevent recurrence. Then recurrent stone formers are one of the most important people that need medical therapy. People with underlying systemic disease that have been highlighted, like renal tubular acidosis, different hypercalciuric syndromes, oxaluria. Then all previous stone patients who have had a surgical intervention and those that have parents or risk factors for stone formation that have been highlighted in previous presentations. Now, for medical therapy, we have to individualize our patients. The importance of this is that the drugs itself has complications and you have to allocate the appropriate treatment, as some medical treatment can actually cause other stones to form. Now, the assessment includes a detailed history of the patient illness, assessment of the risk factors, and other systemic illnesses. Now, my previous speaker talked about the ongoing debate for the enterometabolic assessment. For every stone from everybody with the first-time stone, we have advocated the simple metabolic assessment. But for recurrent stone formers, an extensive metabolic assessment is required because they will benefit from medical therapy. And then for all children who are presenting with stones below the age of 16, we advise that they go for extensive metabolic investigation, because as was highlighted, usually occurs from 30 years, but in children, most likely the underlying systemic illnesses. And then if you get the stone, analyze the stone at least once, because the component of the stone might be a pointer for effective medical therapy. Now, we've talked about this in the previous presentation, and these are from the AUA guidelines, that this group of patients have a metabolic stone assessment, and it's very important that we always remember these patients. Okay, we talked about gout, those with slow anatomical abnormalities have been highlighted already. Now, the categories of medical treatments are within this group. We have the conservative medical therapies, you have the disease-specific therapies, you have targeted chemo prevention of stones, medical expulsion therapy for ureteric stones, and bladder stone therapies. I'll try to go through the different subheadings. Now, the conservative medical management is advocated for every patient who has a stone, whether it's a first-time stone former or a recurrent stone former. And this is the point where I expect we as urologists have to improve. to reduce the recurrence of stones. It stems from the fluid recommendations, dietary recommendations, control of obesity, issues of some cations and anions intake that should be adjusted. Now, fluid recommendations, we usually preach that the patient who has had a stone should drink 3 liters of water a day, pardon me. But really, what is actually recommended by the AUA and EAU guidelines is that the patient should maintain a urine output of about 2 to 2.5 liters per day. So why the input is important, actually measurement of the urine output that is the most important indicator that the patient is actually adjusting and taking this fluid recommendation. So as we have to that, but now this volume of urine is important because it prevents urine stagnation, and then all the different theories that have been highlighted, it prevents that supersaturation, and then also systematic calculi. So we should have to aim to our patients that rather than tell them, drink 3 liters of water a day, we should rather tell them that measure your urine output 24 hours and make sure you are hitting about 2 to 2.5 liters. And I'll tell you, this is a tall task. Many researchers have said that most patients were able to hit about 1.3 to 1.4 liters of urine in 24 hours and not get up to this value. Now, some researchers have talked about the water hardness, saying that based on the concentration of the stone promoters and inhibitors, that can water hardness affect use of hard water versus soft water for prevention of stone, but these are not fully proven. Now, intake of carbonic beverages may show some advantages. Now, the essence of this is to increase the citrate concentration in urine, considering that hypocitraturia is one of the factors that may increase stone formation. And so taking carbonated drinks and also citrus drinks also might help to prevent recurrence of stone by obviating and increasing the stone inhibitor, which is citrate, within the urine. So this is an important point to be considered. Citrus drinks are also considered because it may cause increased acidity of the urine and may also be important to prevent stones. Now, protein restrictions are important. And when we're talking about protein restriction, we're talking about more animal protein restrictions, because our studies show that in areas that have high animal protein intake, there's an increased incidence of renal stones. And as such, we should tell our patients who have had stone before to try to reduce the animal protein. They should rather go for fish or plant-based protein sources like beans, rather than going for the red meats. Okay, because both animal protein is shown to increase excretion of uric acid, oxalate, and calcium, leading to increased occurrence of calcium oxalate and uric acid stone. And this recommendation of protein restriction by the EU is actually a strong recommendation with a level of evidence of 1B. Now, sodium restriction is another important point. Like was highlighted, intake of sodium have been associated with crystallization of calcium salts in urine. So patients will have a restriction of sodium as part of their treatment to prevent stone formation. Now, it's important to know that when you combine both animal protein restriction and sodium restriction in diet with a moderate intake of calcium, stone episodes actually, especially the uric acid stones, reduce by 50%. And this is a very important point for us. So the ability to recommend this for our patients is important for them to reduce their stone burden, recurrence burden. Now, obesity is an important point, has been highlighted by the first speaker as a cause of stones. It causes impaired glucose tolerance, causing increased hypercalciuria, increased BMI, increased weight gain, and large waist size have been correlated with increased stone rates. And as such, when patients are able to control their weights, there has been a tendency to see reduced stone tolerance, stone occurrence in these patients. Now, patients with metabolic syndrome, association of diabetes, hypertension, obesity have been shown to have increased uric acid stone because diabetes causes increased acidity of the urine. And as such, also treatment of metabolic syndrome is important for those patients also to help reduce the occurrence of stones. Now, diets rich in fruits and vegetables is also advised and have been shown to this thing. So these are things we have to try to inculcate in counseling our patients who have had stones before. Now, calcium was said to, since of course stones have calcium oxalate in them, most clinicians were saying reduce your calcium intake in diet. However, that has been proven to be counterproductive because they found out that when there's a reduction of calcium diet in production, actually causes an increased absorption of oxalate from the intestine and also causes increased excretion of oxalate in urine. So the AU and EU recommend that the patient should maintain a moderate calcium intake, especially those with calcium stones, that is important for actually preventing recurrence of calculi. So please, for our patient, they should maintain their moderate calcium intake. In fact, those who have hypocituria are actually told to actually have calcium supplementation, okay, because of so that you can reduce the occurrence of stones. Because when you have vegan calcium citrates, it helps also for excretion of citrate in the urine and reduce stone formation. So it's important. Now, but however, for oxalate has been shown to increase stone formation as highlighted by the previous speaker. And then, so any decrease in oxalate is important. And I've been shown that some diets of foods that contain oxalate like spinach, cucumbers, are all factors that should be considered to reduce in diet so that we reduce the occurrence of oxalate stones. Now, I want to mention about vitamin C. Now, vitamin C, yes, can be taken to acidify urine, but it has been found out that with high concentrations of vitamin C intake, it actually causes increased oxalate excretion in urine. And then considering the fact that within the last 2 or 3 years, we are battling COVID, a lot of patients have been overdosing on vitamin C. And above 2 grams a day have been shown to correlate with increased oxalate excretion and stone formation. So we have to highlight this for our patients, that yes, they can take vitamin C, but they have to limit their intake to less than 2 grams per day. So now these conservative therapies I've talked about are important things that we should highlight for every patient who has a stone, independent of whatever we think the cause of the stone is. They can be helped to really prevent stones. Now I'm going to talk about the disease-specific therapies. And usually this is based on extensive metabolic investigation and the results we have gotten. And a therapy should ideally encompass these 4 points. One, it should reverse physiologic and biochemical derangements. It should inhibit new stone formation. It should overcome the renal complication of disease process and ideally be free of serious side effects. But I would say that there is no ideal disease-specific therapy, but I'm going to try to highlight many of the drugs that we can use. Now, first, I'm going to talk about thiazide. Thiazide is a very important agent, especially in the setting of hypercalciuria, which is we see in, like I talked about in hypercalciuria, the renal type 3, thiazide diuretics, the different doses have been shown to be important in preventing recurrence of stones, especially in calcium oxalate and calcium phosphate stones. Now, for patients with absorptive hypercalciuria in which every other therapy has failed and in the absence of any other metabolic complication, thiazide can actually be given to help stone prevention. And the use of thiazide has been recommended strongly by both the AUA and the EUA guidelines, and as such, is something that we should try to inculcate into our practice. Of course, we have to take note of the side effects of the thiazide diuretics, potassium wasting, muscle cramps, hypocituria in chronic usage. And I thought some people may actually give the thiazide diuretics in combination with amiloride to alleviate some of the symptoms. Now, the first speaker I talked about use of sodium cellulose. This is actually a resin chelator taken orally to try to chelate calcium within the intestines in cases of patients who have been seen to have idiopathic hypercalciuria. It's said to help prevent calcium oxalate stones. Its use is still being investigated. Recently, the American guidelines actually took it off their guideline, but it's still used in the EUA, and because of its complications. Orthophosphate has also been used also. This is specifically for absorptive hypercalciuria, and then it said that when all your treatments are not working, you're trying to use your thiazides, sodium cellulose, orthophosphate to come into play, and it's important for calcium stones. Now, potassium citrate is a very important agent. It is cheap, easily accessible, and has a lot of uses for prevention of stones. It's basically an agent that causes urine alkalization, okay, and it's actually recommended that potassium citrate at 20 milliequivalent twice a day should actually be the first treatment prescribed for patients with uric acid stones. Now, most people will go for allopurinol first, but actually potassium citrate is recommended by the EUA and the AUA recommendation that it should be the first drug in the setting of uric acid stones and not allopurinol. Okay, so it's also important for using calcium oxalate stones. It actually inhibits crystallization of oxalate crystals in the urine because of the increased citrate excretion in urine. Most patients have problem taking potassium citrate because it causes a lot of gastrointestinal upset, and it's important. Now, allopurinol, like I've mentioned, usually in patients with established gout, like a personal history of gout, with hyperuricosuria, and then they relapse after potassium citrate treatment, allopurinol can be used. And it also can be used in a setting of ammonium urate and 2,8-dihydroxyadenine stones when all other therapies and the conservative medical management have failed. You can actually use to a rash also. Now, in the setting of enteric hyperoxaluria or patient with chronic diarrheal states, they have been said to have hypomagnesuria, which increases oxalate in the urine and also calcium in the urine. And so magnesium gluconate can help to prevent calcium oxalate stones. But the side effect of diarrhea has to always be watched for. It can actually worsen the diarrhea the patient already has. Now, pyridoxine has been said to be an adjunct for use in patients with refractory hyperoxaluria. Especially these are the patients who have been treated with both restriction of oxalate in diet, calcium supplementation, and they still have elevated hyperoxaluria in their high oxalate in their urine. Pyridoxine may said to have helped to prevent this as a help. Now, for the cysteine stones, I want to mention that for the cysteine stones, that fluid therapy is the first recommendation for cysteine stones. Adequate fluid, adequate hydration by the patient, reduction of weight have been established. However, for patients who have established cystinuria, the use of mercaptopropyl is actually recommended as the first. Penicillamine also can be used and titrated, but these drugs have not shown very effective. And so for the EUA, they're actually a weak recommendation and used when all the general measures have failed. Now, captopril also has been investigated, but is showing promise in treatment of cystinuria. Now, I want to talk about acetohydrozamic acid. In the setting of Struve stones, which is common stones we see in our practice, especially in the presence of Staghorn calculi with high infective burden. Usually, we want to remove the stone, give the patient antibiotic prophylaxis. But when the stone is being analyzed and we find a high preponderance of urease releasing microorganism on the stone, acetohydrozamic acid actually is a good adjunct for cases of severe infection to prevent recurrence of this stone. It's strong recommendation from the AUA guidelines. For EUA rather, but for the AUA is a conditional recommendation in the present. And it's conditional because it actually has a high incidence of thromboembolic phenomena that must be considered for this patient. So most of these drugs are guided by our metabolic evaluation to make sure that the patient actually warrant the use of these drugs. And it's something that we have to incorporate into our practice. Now, briefly talk about the expulsion of ureteric calculi, medical expulsive therapy. This is use of drugs to facilitate passage of ureteric stones. And it's important that it should not be used in an obstructed scenario. It should be used in patients without obstruction, or with the stone size have been estimated to be less than 8 millimeter. Usually it's said that for stones less than 4 millimeter, 90 to 95% of them are going to pass within 4 weeks. Those between 4 to 8 millimeter, 4 to less than 8 millimeter, about 60% will pass within 4 weeks. But those above 8 millimeter, usually it's not advised for them for us to use medical expulsion therapy. So different drugs combination have been used. We have the alpha-adrenergic blocker, that's tamsulosin, calcium channel blocker, nifedipine, corticosteroid, and adjusting an adequate hydration as an adjunct. Now, the combination of tamsulosin and the corticosteroid have been shown to give the best response to medical expulsion therapy, because the pathogenesis of obstruction of these stones is actually edema of the ureter wall distal to the stone with swelling also. So it's important that steroids be used, the combination of tamsulosin, to actually cause passage of these stones. Some of us use the NSAIDs also to help with it, but also remember that the NSAIDs also have deleterious renal effects. Now, these patients are candidates for monitoring. Monitoring both clinical and radiological, because it's important that they should not be worsening of the symptoms within this period of time, because worsening of the symptoms or including sudden onset of high fever, because urosepsis is a complication of medical expulsion therapy, increasing pain, are indications for urgent surgical intervention. And if the stone doesn't pass within 4 weeks, it necessitates a surgical approach. Now, some of these drugs is also an adjunct for us during after extracorporeal shock wave lithotripsy and laser lithotripsy to facilitate passage of stone and reduce stone retention. So this is an important point also, but it has to be used within the appropriate clinical scenario. Now, bladder stone generally, we know the treatment of bladder stones are surgical. Some people attend for females with small stones to try to pass it, but the trauma they have trying to pass out those stones is excruciating and increased risk of infection. However, stones associated with prolonged indwelling catheters or tubes may be preventable. Generally, we tell this patient to have adequate hydration to reduce encrustations on the catheters or the tubes, but we have to try to inculcate the practice of using irrigating the catheter from time to time. The menacidine, which is a combination of citric acid, gluconol delta lactone, and magnesium carbonate irrigation, have been shown to cause dissolution of struvite bladder stones associated with encrustations. Also, 0.25 or 0.5% acetic acid solution may be helpful also. In fact, they said that even irrigation with just normal saline, also with adequate intake and urine output, may reduce the risk of encrustation, among other factors related to the catheter. So this is an important point for the patient. Now, there are some miscellaneous scenarios that are important. We talked about renal stones in children, and usually they have a systemic cause. Renal tubular acidosis is a common cause, and usually these patients, these children, we want to do a combination of thiazide and potassium citrate also for that treatment, in addition to treating the acidotic patient. Sometimes we see very young children with multiple stones within the renal parenchyma, and they find that these are children who have been on management for different renal conditions like nephrotic syndrome, who are on loop diuretics or glomerulonephritis, and they can come down with this. So cessation of the loop diuretic may cause a reversal of the increase of stone deposition within the renal parenchyma. We've talked about the drug-induced stones, which are highlighted, and cessation of these drugs is a preventive strategy after treatment of the primary stone. Now, stones in pregnancy, the tendency is going toward more of medical treatments because of the stasis that occurs within the urinary tract, both physiological and anatomical, with the growing uterus obstructing the ureter. There may be increased stone formation. Also, there's low estrogen within the pregnancy state, so the protective effect of estrogen against stone is lost. But it's advisable for prevention first. The adequate hydration is important. Treatment of infections with antibiotics that we know that will not be harmful to the uterus is important. For these patients, diagnosis of these stones usually is advisable via ultrasonography, with trying to reduce radiation risks to the fetus. But in the case of symptomatic stones, there may be need for intervention in discussion with the gynecologist to find out the adequate semester, whether the second, first, or third trimester. And towards the end of the second trimester usually is the best time that have been shown to treat stones in pregnancy. Now, follow-up of patients on medical therapy is important, especially those on disease-specific therapies, because these drugs have been known to cause deleterious complications, to change the biochemical milieu of both the blood and urine in patients, and therefore follow-up is important. Now, it's advised that within 6 months of commencement of any medical therapy, you should take a 24-hour urine and measure those metabolites highlighted by the last speaker to ensure response of therapy also. And then periodic blood testing is important, and these two recommendations are strongly rated by the AUA. Now, follow-up imaging and stone analysis may also be necessary, not just one analysis, because during medical therapy, there may be conversion of the type of stone you are seeing. So you may set out to treat a calcium oxalate stone or calcium phosphate stone, and with chronic thiazide therapy, you start having uric acid stone. So it's important to actually do a stone analysis from time to time to determine the ideal treatment to continue or to stop. So in conclusion, I want to say the medical therapy aim is prevention and reduction of stone recurrence. And like I said, the fluid and dietary recommendations are advised for all patients with both high stone disease. Metabolic workup is important, and then we should consider more local oriented research, both into the foods that may contain these stone inhibitors or promoters, and drug treatment to prevent stones, and then help and reduce the burden in our patients. These are my conclusions. Thank you very much.
Thank you. Thank you very much, Dr. Opani, consultant neurologist at the University of Port Hospital. Today, we shall be taking commentaries and questions at the end of all the 4 presentations. We will now move on to Dr. Magnus, consultant neurologist at the Chiva Specialist Hospital and Neurology Center, Abuja, who will be speaking on the principles of extracorporeal shockwave lithotripsy, ESWL, in the management of urolithiasis. Dr. Magnus.
Sorry, my moderator, we will take him the next presentation.
Okay. So, in other words, we are shifting the ESWL to the next presentation.
Yes, sir.
Right? To the part 2 of the presentation, right?
Yes.
Okay. Okay. Thank you very much. As you've just heard, the last presenter's presentation will now take place during the part 2 of this session, urolithiasis. So, ladies and gentlemen, you have listened to 3 excellent presentations. The first one from Dr. Rufus Ojewala, consultant urologist at the Lagos University Teaching Hospital. And I think the main highlight from this presentation was on the prevalence of urolithiasis in Nigeria. From about 1978, when one of the pioneers of urology in Nigeria said it was very fair. So very recently, when we have seen hospital prevalence rates of 13.4 to 19.1 per 100,000. I would say that these are probably the tip of the iceberg, and I hope that in the future we have a national prevalence study, because as we are acquiring more and more technology to deal with stones, on the one hand, our patients becoming more and more aware of it, increasing awareness in the population, we are seeing more and more stones. I think my main takeaway from Dr. Ojewala's presentation was that a patient presenting with a stone is actually presenting with a symptom and sign, and that he must make the effort to find out why it's got stone. So it's not sufficient to treat the stone. You must find out what is causing the stone and direct your treatment of it. The second main takeaway point of interest to neurologists is that the commonest type of stone in terms of chemical composition was calcium oxalate stone, which may be metabolic or dietary. And then I think those were the main things from the etiology and genesis of stones from Dr. Ojewala. Then we went on to the presentation, the clinical presentation and investigation by Dr. Naus, consultant urologist at the Nisa Premier Specialist Hospital, Abuja. We learned that the stones can, on the one hand, be asymptomatic or present with a symptom complex, which will range from pain, obstruction, infection, or sepsis. And then he told us about the various ways we can investigate the patient, from plain X-ray to ultrasound, to CT scan, to nuclear medicine, blood investigations, urine investigations, the metabolic screen. And I saw somebody ask, what are the basic investigations that should be done mandatory for a first-time stone former? I will leave that for the session and discussion. And then we listened to the principles of medical treatment delivered by Dr. Opani consultant urologist at the University of Port Harcourt Teaching Hospital, reminded us that apart from surgical treatment, which we tend to focus on, there is an array. There are several medical treatments. There are certain conditions that are medical that lead to stones, and that the treatments could vary from diet to fluid to weight management and to drugs. And I think it's a complex subject, very confusing, but I think Dr. Opani did very well to simplify a very difficult subject. And I think we should thank him for that. And actually thank all the presenters, because urolithiasis is a very wide subject, and they have done their best to present it in a way that it is accessible to the general urologist. Thank you very much. I will hand over to Professor Ikeke now, and the chairman, Dr. Adozie.
Okay, we have some.
On the next aspects, yes.
Yes, we have some questions here. Dr. Agnes is asking, what are the commonest causes of urinary stones in Nigeria? I think that should be to Ojewala.
All right, thank you very much. Yeah, thank you very much for that question. It is very, very difficult to say that something, either a disease or a factor, is the commonest cause of stone in Nigeria. I think it's a combination of factors as it is now. First of all, there's no data or studies that have studied the etiology and put it on record that so and so are the commonest cause of stones. So most studies that we have on stone disease are still prevalence studies. None has actually talked about what is making patients predisposed to forming stone. I mentioned 2 studies that have attempted to analyze the composition of stones, Mecca et al. In Enugu. And the conclusion was that calcium-containing stone is still the commonest, followed by strophyte stones. So another one in Abuja by Ondi et al. Also stated that calcium oxalate, followed by calcium phosphate and uric acid are the commonest in terms of composition. So for us to know which one, what is the commonest factor predisposing a patient to forming stone, we may need to evaluate these conditions. How many patients have absorbed hypercalciuria, how many patients have resorptive, and a lot of others. So I think this is a challenge to all of us. We were mentioning prevalence from across Europe, from America, but we do not have a national prevalence, and we need to work on that from individual centers. I think Naus need to do something about that so that we can have a data that we can put out to the world that in Nigeria, a disease that is previously thought to be rare is now very common, and this is the status. Secondly, it is not enough for us to remove stones. I think we should have more and more of stone analysis, and that will form the basis for going back to the etiology. And we need to evaluate our patients very well with a mind of getting to know what predisposed them to developing stone. Then we can come with facts that these are the commonest causes of stones in Nigeria. As at now, I don't have an answer to say this is the commonest cause, but we need to work in that regard, and it's a collective responsibility for all of us. Thank you very much, sir.
Thank you for the response, Dr. Ojewala. As you know, many of our university departments, urology, not have access to stone analysis. The chemical pathologists are yet unable to offer that test. I don't know what the problems are, but I think it's a big problem for them. And as you say, once we are able to do that, it will go a long way to answer this question. Thank you. Professor Ikeke.
Okay, thank you very much. We thank you for your questions. Dr. Nabasu, there's a question from Abubakar Sadiq. to you and also from Professor Taylor. The first question is, what are the basic investigations for first stone formers? The basic investigations for first stone former. And then also to you, Dr. Nabasu, from Professor Taylor, say CT KUB, CT urography, and CT IVU. Which one do you prefer? Dr. Nabasu. Dr. Nabasu.
Okay. Thank you for the opportunity. The first question, what are the basic investigations for the first time stone former? Like I mentioned in the presentation, one of the slides, basic investigations will include a urinalysis and then a stone analysis, if at all we can retrieve a stone, as well as serum chemistry including urea electrolyte creatinine, as well as calcium and uric acid. A full blood count is also important because some patients might actually present for the first time with stones with some hematological disorders that may not have been diagnosed, predisposing them to stone formation. So that's the first line, that's basic investigations for a first time stone former. So if I've forgotten something, maybe the house can add to it. Then the second question is about KUB, CT KUB, CT urography, and CT IVU. I think we need to clarify some of this. I may be wrong. I think CT urography and CT IVU mean the same thing.
Yes,
hello?
Go ahead.
Okay, then they mean the same thing, CT urography, CT IVU. And then CT KUB, non-contrast CT, if I'm right, just without contrast. So the choice is between a non-contrast CT and a contrast CT. I think I'll go for a contrast CT because in most cases, if a diagnosis of a ureteric stone is to be made, because some causes of hyperdensities in the abdomen can be seen on non-contrast CT. You won't know whether they are in the line of the ureter or not. But if you give a contrast, you can easily differentiate between some of those causes of hyperdensities and a stone in the ureter. So that's the answer I can provide for the question ordered to me.
Okay. Thank you very much.
I'll just make it. Dr.
Nabasu.
Dr. Nabasu kindly
Yes,
invited more comments. I mean, as part of the basic, as rightly mentioned, the basic, the physical count, the electrolytes, the analysis and culture. And of course, I think that in an environment where we do not have access to analysis of stone, I think a limited metabolic screen, the calcium, the phosphate, and the uric acid should be performed. We do that routinely in Benin, calcium, phosphate, uric acid. All right, for all new presenters with stone. And if they have risk calcium, then we go and do their parathyroid. And then in terms of the investigation, I think a CTKUB, I think the limitation we have is going to give contrast to these patients with more radiation is because of one, most of our radiology departments don't have a CTKUB protocol. They are not familiar with it. Some of them are not familiar with that protocol. You book a CT scan, you are told, the patient has to go and clear the bowel and all that. So you're going to work with the radiologist to look at their CT protocol. Now, the CT machine they are having may be of a low resolution, so the CT machine might not be of much help. It may not get a good result with the CT KUB. But I can tell you, an experienced radiologist who is looking at the non-contrast study will be able to tell you, where a stone is, the density of the stone, whether it is causing obstruction. And by all means, you can always come back later to do a contrast study if you still need to do it. But we need to still work with our radiologists on that. Thank you.
Okay. Yes.
Okay. Oluwatomi Odutola, I don't know whether you're satisfied because the same question is, what is the role of non-contrast pelvic CT in emergency stroke elective evaluation of urinary tract stones? The role of non-contrast abdominopelvic CT.
I think that addresses in the emergency setting. In the emergency setting, you don't need any operation. The CT KUB. All right. Then later do that. But as I mentioned a short while ago, the problem is getting that CT KUB done. The radiologists are very keen to give contrast. We haven't given contrast before this is true. If you look at the history of CT KUB, when it was first introduced, or at least from UK experience, the radiologists were missing it initially because they cannot identify the stone or the phlebolith on the plain CT KUB. But with more experience, they get to be able to do that. And emergency setting a CT KUB. If you can, if the radiology department is open to do a CT for you in the night, anyway, which is difficult often. Thank you.
Okay, still on this subject, Dr. Iken Nanabugo is saying that he's of the opinion that non-contrast CT is the preferred CT modality. The CT urography helps outline the urinary tract for more details. Okay.
That's incontrovertible. That's exactly right. But what we're saying, the question we're addressing is a man comes into the emergency room, he's in a lot of pain. All right, he probably has high creatinine, he's vomiting. All right, he has not prepared his bowel as the radiologist would require for the normal CT IVU. All right, then you can just put him to the CT for a plain CT. KUB. You can get inferences of what might be going on. You can always come back later. You can come back later to do a contrast study. What we are saying is that in that emergency setting, the CT KUB, it's like a placeholder. You do the CT KUB while you are waiting to do the follow-up CT later. What I have tried to do, for instance, to save money for the patient, is for the patient to do the CT KUB. And I say, you hold on with your contrast. The patient is going to come back to you later to continue the contrast study. And you can then add more money for him to pay so that you can get the contrast study. But obviously, hospitals don't distinguish between CT KUB and CT IVU. They charge for everything. All right. It would be nice to hear from Dr. Azodo on this. I don't know what happens in Chiva Specialist Hospital, where they have a CT scan on the ground. This is a urology center. They've got a CT scan on the ground. All right. They do CT IVU as a medic, or they do a CT KUB. And then the contrast study. It would be interesting to hear Dr. Azodo's views on this.
Okay, while we're waiting for Dr. Azodo, Abdullahi Abdul-Wahab also says that contrast CT is the gold standard in urolithiasis. The opinion of Abdullahi Abdul-Wahab is that non-contrast CT is the gold standard in urolithiasis. Dr. Marcelo, please, we are not allowed to make comments, so send message and I will read your message.
Okay. Can I make a little comment?
Go ahead. Can we see? Okay, comment. Okay, make a comment before Dr. Azodo.
Still on the non-contrast CT, I thought the usual protocol and the routine is that once you request for a CT IVU, the non-contrast CT is the initial stage. They usually they give you a non-contrast CT before the CT IVU. But sometimes when it is obvious and you're able to see it before they proceed, you can ask them to stop at that level. But non-contrast CT usually comes before the CT IVU. Isn't that enough to give us the information we're looking for?
Okay, Chief Azodo, can you tell us your experience?
Thank you very much. When you read a lot of the
I'd like
initial...
to see your face if you don't mind.
Oh, sorry. My face, where's my face? Okay, I can see my face now. Good evening, everybody. You will find out when you read a lot of the article, first of all, what people always ask for is a non-contrast CT. But you will find that if your work is basically endourology, you will find out that you need to have a contrast CT. And like Nabasu said, the first thing you get when you ask for a CT is a non-contrast CT before you do the contrast. But you will find out that that is usually not always enough. If you're going to do something like PNL, when you need to know the location of your calyces to be able to get your stone properly, you probably will require a contrast CT. So a contrast CT will be my preference. But of course, if there's any limitation like serum creatinine, a plain CT we have to do. Thank you.
Thank you. We don't have more comments. We only have commendations for all the speakers. Okay, now Nabugu is also saying that because of our peculiar setting, to avoid patient visiting radiology suit multiple sites, CTU plus, that is CT urography, is done at one visit. That is CT and CT urography is done at one sitting. That's a special condition, taking the logistics into consideration and the patient pocket. Okay, so we have mainly...
There's a comment by Abdul Wahab.
Yes, I've already read it.
No, there's a second comment.
Right.
This, I'm not aware this has changed. There is no oral or IV contrast in this image. It has the advantage of picking out as small as 2 mm stone. That I agree. However, before you do a contrast CT, the first shot is done contrast. So that takes care of that. But that will also depend on the resolution of your CT. If the CT less than 16 slices, you probably don't get that kind of resolution. Thank you.
Yes, he must have sent it to you personally, not to the forum.
Okay, yes, it's to me. Yeah, okay, that's
okay.
True.
Okay.
I think to make this easier for urologists, they should work with their radiologists to work out a protocol for CT imaging of patients with kidney stones. I think it will help. So that when you fill a form, you want a CT KUB or a CT IVU, they are not going to throw the form back at you. They know exactly what you're looking for, and you put it in your form. All right. So a CT, a radiologist should be able to offer both without question. Say, I want a CT KUB or a CT KUB protocol, or I want a CT IVU. Right? Of course, there are, as has been mentioned, there are good reasons. There are arguments for and against based on radiation exposure, and all that. But in the emergency room, the patient are just coming. The CT KUB, you can only do your contrast later. Thank you.
Okay.
If I may
Yeah,
say so, I think Dr. Tell also we had meant an IV instead of a CT IV, because the people who have argued that on the table what you have access to is equivalent of a plain IV when you do a retrograde, and as such that a CT IV is unnecessary because you won't have it with you on the table when you're working. But you need it because before you go to do a PCN, you need to study your CT IV before you go in. It helps with your orientation on the table. Thank you.
Okay, there's another comment from Abdullahi. He says, for the benefits of exams and residence with us, standards first, then peculiarities later. So what is the gold standard? That's what we should know. Then we can use our peculiarities. Like, what is the gold standard?
The gold standard, sorry, I didn't quite get that. The gold standard for?
It says, for the benefits of exams and residents are with us here. So we should know the standard. So when you have when you're in the exam and you're asked about the investigation, which one would you prefer? Is it contrast?
I think it's CT.
Okay.
KUB, please.
Yes.
Okay, there's another comment. Please let us avoid using CTKUB. It does not convey the intended meaning.
But that is what it is called.
There was a question now. There was a question I just saw.
There's another question. Yes. Marcelo, you're welcome. Can urinary stones be passed out during micturition? Okpane.
Yes, thank you for the question, Master. Can you hear me? Urinary stones can be passed. You know, we talked about the size. Now, we have been estimated that when the size of the stone is less than 4 millimeter or 0.4 centimeter, in 90 to 95% of cases, the stone will be passed into the bladder from the kidneys. And then when you have between 5 to less than 8 millimeter, about 60 to 50%, but above 8 millimeter, it may not. So yes, stones can be passed. And you also know that if you look at the pathogenesis, we actually pass out very microscopic stones on a regular basis with adequate hydration. If there's any nucleation that has occurred, it can be passed out. So yes, it can be passed out. But the point is that when you're having a stone size and presence of symptoms, you should not start waiting to push out the stone via hydration to actually intervene. You understand? But adequate hydration has been shown to be a preventive measure, even from having stones occur at the first place, especially with our hot tropical climates and areas of high calcium listing in water. Thank you very much.
Okay, there's argument going on here. Non-contrast, contrasted CT, CTKUB, CTKUB. So can we clear this argument? Dr. Navashi.
May I throw it back to my teachers?
Okay, Chief Samuel, so Chief Osaya.
Yes. Sorry, I didn't get that.
There's an argument whether we should use CTKUB, non-contrast CT, contrast state type.
I think those are just semantics. I mean, non-contrast CT is clear. I mean, what is KUB?
Okay, so
contrast CT. You can say contrast CT, contrast CT KUB. You know.
Okay.
I think for the purpose of exam, non-contrast is
non-contrast CT for the purpose of exam.
Yeah, the preface non-contrast. Yes.
Okay. Okay. It has been we just have 4 more minutes to go. Before I hand over to the chairman and moderator, Port Harcourt is ready for to host urology. We have a exciting place, very nice venue. We have parallel sessions. We have added city tour. We have arranged and brought down the rate of hotels. So please, we're expecting your yeah, we have brought down the cost of hotels. I mean, we have looked for hotels and not as expensive as Abuja though. And yes, and we have further extended the call for abstracts to 21st of this month. That will give us 1 month to the date of start of the conference. So please, we want to thank those who have started registering, and we want you to please, no, there's nothing about Wike there, Ikurowe. We are, there, I can assure you, we are not inviting any politician. Huh? We're not inviting any politician, so don't be scared.
Now it's part of the delegate money.
So no, there's no politician coming to our opening ceremony and everything. So we are going to be very professional. So we want to see you, Ikoro. We don't be afraid. Whether you're Wike, whether you're Atiku, or obedient, or petrified, whichever one you are, they will not play part in that in Port Harcourt. I promise you that. So we have made a lot of, we have done a lot of work waiting for you to come and participate. That is one. Number two, we can see what is playing out in Stone. We have similar thing in prostate cancer. So we have started a national study. We started with advanced prostate cancer, getting some data on androgen deprivation therapy. We have extended this invitation to several centers, and we have started getting results. The preliminary study will be presented in Garden City 2022 before we start a prospective study that will give us all the data we're looking for. So please, if you're,
thank you.
If you can inbox me if your center is not involved in the place yet. We also sent out questionnaires. You know, part of our team is about urology training. That is our sub-team, is training of urologists. So we sent out Google form questionnaire about residency. So we please want to appeal to all the people who are residents, and then those who have completed residency in the past 5 years, to please fill the questionnaire. It will help us to evaluate training of urologists, to know the challenges and the gaps you need to fill. So please, we'll put the questionnaire again in both in the Naus forum and all the other. So just click if you have just finished residency within the past 5 years, or you are a current resident. So please fill the questionnaire. It will help us. It will be one of the things that will be presented in Garden City, in addition to the one on advanced prostate cancer. Thank you very much. Let me hand over to the chairman and the moderator. Thank you very much.
Well, I will just speak, and the chairman will have the last word.
Yes.
Now, time is fast spent. We spent 2 hours. We thank our I counted at a point about 120 participants. I want to thank you first, the audience, for making this possible. I want to thank the 3 speakers, and I want to thank our chairman for organizing a very lively session. And I also want to thank Professor Ikeke for the rehearsal yesterday to prepare for this meeting, which has helped a great deal for us to keep to time and to deliver as we were expected. Thank you very much. Over to you, Dr. Azuba.
Thank you very much, Mr. Moderator. Thank you for all the speakers.
Dr. Azuba, please.
Yeah, I'm on. Can you hear me?
Yes, you can, sir.
Dr. Azuba is not.
I want to thank you for excellent work done. It's unfortunate we couldn't take the one on ESWL because one of the things that we wanted to highlight is the fact that for ESWL, CT density is very important in determining what you do with the patient. I'm sure we'll take it next week. I also want to thank the presenter for excellent delivery. I hope that the residents learned a lot for this, because when it's a medical treatment, a lot of people don't think it's a big deal. I'm sure a lot of us are living this way, knowing that medical treatment is a big deal because we often ignore medical treatment in favor of surgical treatment. Next week, on the 22nd, we'll deal with surgical treatment. I'm sure there'll be a lot of fireworks and controversies. I hope we can finish it that day. Thank you very much. God bless you. See you on the 22nd.
All right. Thank you, sir.
Okay.
Thank you, sir.
Somebody asked whether we will have the Zoom link, whether we can download the presentation. We have a Naus YouTube channel, and then we will also send the link for this. It's recorded already, so usually it will take some time to upload. So by latest this night or latest tomorrow morning, we will have this presentation in our YouTube channel, and the Zoom link will, a link will also be sent to your OneDrive, so you can get the presentation. Thank you very much.
All right. Thank you, sir.
Thank you.
Thank you, sir. Thank you, sir.